Dear students, today this class is roots of drug administration. I have already talked about the different formulations, what are it is, pros and cons, what is the consistency, what is the compatibility, what is the how you should select the route, and how you have to perform this exercise. This competency is very important. This roots of drug administration. Now I am talking about the classification of the routes of administration. It is very important. You should know about its classification. Classification can be divided into two parts. Number one part is the systemic, another is the local. In the systemic, it can be subclassified in enteral, oral, sublingual, and rectal. And systemic can be parenteral, inhalational, injection, and transdermal. And injections can be intravenous, intramuscular, subcutaneous, intra-arterial, intra-articular, intrathecal, intradermal. But local can be second, topical, intranasal, ocular drops, mucosal throat, vagina, mouth, and ear, and inhalational transdermal is also in the local. But why it is in the parenteral? Because once you give the inhalational, like in the anesthetic agents and transdermal, it has to reach the systemic compartment. That's why it has got in the parenteral also as well as in the local also. So this is you should all enumerate the examples. Examples make a good sense once you write the examples in some routes, and that can clarify that there are triangle, drug, disease, and destination. Drug means the physiochemical properties of the drug. Disease means where it has to reach, and destination. Drug, disease, and destination. Destination is effector site, where it has to affect. So drug is given, then it goes to various membranes, then it reaches the in the systemic compartment. From systemic compartment it goes to the effector site, that is the destination. So this is very important. Suppose these are the different routes you have given. There is a sketch diagram. There is a rectal. There is topical. There is a transdermal. There is oral. There is inhalational, sublingual, and parenteral, intravenous, intramuscular, and subcutaneous. So this you have to enumerate in your practical notebook. Enteral is oral, sublingual, buccal, rectal. Note soluble, enteric coated or slow release formulations are in the enteral, which we give in the through oral, through mouth. Parenteral is in intramuscular, intravenous, subcutaneous, intradermal, IT, etc. This is a different rates of the absorption, different plasma peaks, and note IV is infusion. IV is also infusion. So it depends. This parenteral, where I have enumerated some examples, this depends upon the particle size and the site, and it is a physiochemical property of the drug, and it has to reach the, suppose you give the subcutaneous is the insulin. So insulin is slowly releasing, and it maintains the glucose level. So insulin is we inject, and it maintains the glucose in our body. So hyperglycemia to hypoglycemia, we have not to give that much high international units so that it will lower the glucose level, and there is a hypoglycemia. So this is very important to note down. And then we have a second for local systemic or systemic effect, note by patch. So this is also second. Do you need locally or do you need systemically? Because there are some drugs which you give second, it reaches the systemic compartment. There are some drugs which you give the in the eye or ophthalmic, it reaches the systemic compartment. So that should not hamper, that should not give that toxic effects, because the systemic effects are more having toxicity. Suppose take the case of the chemotherapy. You give IV, it has to reach the cancer part, but it also does other things, does side effects, side ADRs. So this is very important. Lungs, inhalation and local or systemic effect is also there. So vaginal is usually local, eye is usually local. So you have to enumerate. There are some routes which are locally taken care of, but they go in the systemic compartment, like inhalation I told you. So this is the factors governing the choice of tools. Physical and chemical properties of drug I told you very important. So the pKa, pH, and is it solid, that I already told, solid, liquid, gas, solubility. solubility is very important, pH is very important, irritancy. So these things, suppose I told you the example last time in the phenytoin. Phenytoin was not a soluble product. Then there was I would say phosphenytoin, which is soluble, it is easily taken, and we can give in the emergency also, we can in infusion also. This is also very important here. Site of desired action, localized and approachable, or generalized and non-approachable. So approachable and non-approachable is also site, because it needs a experienced person. It is expert, to do that injections, and also it needs some surgical intervention like intrathecal. Suppose rate and extent of absorption from various routes. So it depends upon the bioavailability. Take the case of the antiviral, their bioavailability is less, but they reach the target site with 24% of bioavailability. But if you take the same case as diazepam has 100% bioavailability if you take orally. So effect of digestive juice and first pass effect is there. These are the factors governing the choice of the routes. Rapidity of the desired response. So for emergency, you give the dopamine. You can have you should give in the emergency because its half-life is very, very less. So half-life is also determined upon these factors, the physical, chemical factors. Routine we have not some drugs we have not given routinely in the emergency. So in the emergency case, in the emergency care, what are the drugs which are very important, and what are the emergency drugs which you have to keep reserved for those patients or poisoning patients or emergency patients which have got hypertension is more than 220, so you have to deal with that patient. And accuracy of the dosage is very important. That I have told you about how to make the dosage forms, how to preserve them, how to make them, in the cold storage. That is very important. Conditions of the patient is also important. If it was unconscious and vomiting, if it is a vomiting, we cannot give, oral. Or it is unconscious, we cannot give oral. So that's why the anesthesia, the patient is unconscious, we have to deal with the IV, drugs, and we have to give them IV. And what are the pre-anesthetic agents, and during the anesthesia, and during the procedure, and after the anesthesia, post. This is very important. You have to take the care of. Now, oral route, I will first. The most common route of administration, drug is given through oral cavity. Advantage is safe. It is convenient, self-administration can be done. In the elderly, we have to give them, we have to ensure that, because this forgetfulness, we have to ensure that the elder patient is taking drug or not. The pain-free, there is a non-invasive and easy to take. These are the advantages, these are the convenience. These are the convenient points we have. Economical compared to other parenteral routes. Usually good absorptions there take place along the whole length of the GI tract. There is a vast area. It starts from the mouth till the rectum. So all along absorption takes place depending upon the pH, depending on the pK, depending upon the blood flow, and all these things are very important so far as passage diffusion is concerned. No need for sterilization. So we don't need sterilization. We have just to should have a good hand, and then full of water, and then we can take the drug. And then this oral route is disadvantage, slow absorption is there, slow action is there, cannot be used in emergency. So you need to, decrease the blood pressure. In the emergency, you give that drug which should be given IV or in the infusion, and you cannot give the oral at that time. So depending upon the suitability time, this depending upon the patient, and the irritability and unappellability drug, nausea and vomiting, it occurs. Cannot be used uncooperative, vomiting and unconscious patients. We cannot give oral route because they will go to the bronchus and the patient can die. And some drug is destroyed in the GIT because we cannot give the aminoglycosides through the oral route, because we cannot give the insulin through the oral route, because you should know, as a practical students, as a practical note, you have to have these drugs for several drugs which are being destroyed in the stomach. Sometimes inefficient drug absorbed. Some inefficient drug absorbed. Some drugs are not absorbed, like streptomycin. I told you aminoglycosides like streptomycin, amikacin. Like streptomycin, it has given here example because of the, we give this streptomycin in the ATT. first pass effect due to the biotransformation. So once we give the drug orally, there is the biotransformation before the systemic compartment. At GIT, it will go through the hepatobiliary system, it will go to the liver, while it will be detoxified or it will be biotransformed. There is a CYP cytochrome 450. So food-drug interaction and drug-drug interaction occurs during the oral route. So the bioavailability anyhow is less. So there is a food-drug interaction or drug-drug interaction. If we have 2-3 drugs, because sometimes it is not the absolute only one drug which is given, there are 2 drugs, 3 drugs, 4 drugs, depending upon the severity of the patient. In the cardiovascular, I have already told there are 20 or 18 or 15 drugs to be taken at a time. A person having the diabetes, a person having the hypertension, a person having the, so many diseases, comorbidities are there. Now, the dosage, capsule form, powder form, and tablet forms, spansules, syrup, emulsions, suspensions, elixir, and these are the tablet form. This is the hard gelatin form. These are soft gelatin. Spansules. There is syrup. So depending upon which the drug molecule is intact, the drug molecule is stable, and depending upon what are the different forms, dosage forms that I have already enumerated. Sublingual and buccal route is very important. Tablet or tablet or pellet containing the drug is placed under tongue or crushed in mouth and spread over the buccal mucosa, that is GTN, glycerol trinitrate. So this is the sublingual. You have to keep in the emergency. There is the blood pressure. Blood pressure is very, very high. Keep some nifedipine, or you can keep it in below the tongue, and you can this sublingual route, and it can be once the blood pressure comes to the normal, and then you can spit it. So it is controllable. No advantage. Drug absorption is quick. Quick termination is there. First pass is avoided because it is 100% sublingual, can be self-administered, economical. So what are these unpalatable and bitter drugs? There are some drugs which are irritant, which are colored, and which are irritation to the oral mucosa. A large quantity is not given because we cannot have control there. You have to put it there, and that's why we cannot control large quantities, and few drugs are absorbed. Now, rectal route drugs that are administered rectally as a suppository. In this form, a drug is mixed with a waxy substance that dissolves or liquefies after it is inserted in the rectum. That is diazepam, we have indomethacin, paraldehyde, ergotamine. These are the drugs which are given through oral route. So this rectum is also, there is not a first pass effect, is not there. But if you give the deep rectum, yes, there is. So advantages are used in children, because in children we can have problems. They cannot be, cooperative. Little or no first pass effect. So hemorrhoidal vein, used in vomiting or unconscious state, higher concentration rapidly achieved. So, but disadvantages, inconveniences, absorption is slow and erratic. Irritation or the inflammation of the rectal mucosa can occur. So there is some disadvantage also to the rectal route. And then we have parenteral route. That of the drug into the systemic circulation without intestinal mucosa. Intradermal we have into the skin. Subcutaneous we have SC into the subcutaneous tissue, like we give the insulin. And intramuscular we have into the skeletal muscle, like we have all antibiotics and water, vitamins. And intravenous we have into the veins. Intra-arterial we have into the arteries. Intrathecal we have cerebrospinal fluid. It should reach there. It should go to the central, BBB, blood-brain barrier. Intraperitoneal is there. There is a peritoneal cavity. It's a very large cavity. We can give, anti-rabies, dog bites and all that. Intra-articular is there, synovial fluid, because in arthritis we have to give the intra-articular. So this is very important. You have to, enumerate. You have to remember these routes. Now we have intradermal injection into the skin. So I have already told you about the position, about the degrees under which these, how you have to press the needle, and this is very important. And intradermal injection into the skin, subcutaneous injection, absorption of drugs from the subcutaneous tissue. Intramuscular is drug injected into the skeletal muscle. Then we have intravascular IV, placing in the drug directly in the bloodstream. So the position is very important. What should be the gauge? You have to mention yourself what are the different sizes of the needles, and how you have to keep the drug in the syringe, how you have to take out the drug from the syringe, from the vessel to the syringe, and there should not be air. It should be air, should not be there. Otherwise, if you go IV, that there will be air bubble, there will be embolism. And then first pass metabolism we have to define. Metabolism of drug in the gut wall or portal circulation before reaching the systemic compartment. So before reaching the systemic compartment, it goes the gut wall or portal circulation, and it is being metabolized by the SIPs. And so the amount of the reaching systemic circulation less than the amount absorbed. So how much drug you give, it is not reaching the systemic compartment. Suppose you have a 500 milligram tablet you are taking through the mouth, and it is not reaching the systemic compartment, fully 500 milligram. It will be 400 milligram, 350 milligram, then it will go to the effector site. So where it is in the liver, in the gut wall, in the gut lumen, and result is low bioavailability, short duration, so half-life, depending upon the half-life. Now this is oral. Drug is administered IV, enter directly into the systemic circulation, and have direct access to the rest of the body. So this is called as which are given IV. So it will reach the systemic compartment fully. Then it goes to the liver. So rest of the body goes. But once you give the first pass metabolism, can be given with orally administered. So drug is administered orally or first exposed to the liver, and may be extensively metabolized before reaching the rest of the body. So this is the difference between the bioavailability is full when we give the IV, and it is not full. But in some cases there is orally given. So take the case of diazepam, it is 100%. So this is one of the examples. So this is the general circulation, and this is the liver, where this portal system is directly connected to the GIT. Now we have parenteral administration advantages and disadvantages. High bioavailability. We have a rapid action emergency. No first pass metabolism. There is no first pass. So suitable for vomiting and unconscious persons. For that person, these patients who are vomiting and who have unconscious state, we can give the parenteral administration. Irritant and bad taste, because there is irritation like in the sublingual also, and no gastric irritation, no food-drug interaction, because we give 2-3 drugs orally, so there is a drug-food interaction, like we have a digoxin and we have a cholestyramine. And dosage form, vial or ampule, so it is always in the vial ampule form. So disadvantage, infection is there, where it is not in the oral. Sterilization is very important. Invasive assistance requires. It is very expertise technique, and pain will be there. Need a sickle, expertise. Doctor, anaphylaxis is there. One of the drug is given, it produces the anaphylaxis. So we cannot take the drug back. In the oral, we can give, dextra, we can give, charcoal, we can, there is a forced vomiting we can have, but it is anaphylaxis. During anaphylaxis, we cannot do anything. We have given the drug, we have to take other, necessary actions, like we have to give the adrenaline, we have to give the steroids. And it is very expensive. So this is the disadvantage. So you have to enumerate the advantages and disadvantages of the, these drugs. So this is the ampule, this is the infusion, this is the vial, and this is the, ampule. So it should be cut like here, and then should be inserted into the syringe. Now intravenous route, advantages. IV is the most common parenteral route. It is most common for drugs that are not absorbed orally. Avoid is first pass metabolism. There is avoidance of the first pass metabolism. Intravenous delivery permits a rapid effect and a maximal degree of control over the circulating levels of the drug. Titration of dose with response. So how much dose you give and depends upon the brisk response. And then large quantities can be given fairly pain-free. So we can give large quantities, 100% biology is there. We can give infusion also. Infusion is also intravenous route. So 100% bioavailability absorption phase is bypass. There is no absorption phase is not there. So you would have taken note from, suppose this is the plasma concentration, this is the time. So it is given like this, it will come like this. But in oral it is like this and it is like this. So this is however there is no absorption and there is to some extent distribution and there is elimination. So however, unlike drugs in the GIT tract, we have those that are injected cannot be recalled by strategies such as the emesis or by binding to the activated charcoal. So this I have told is the disadvantage. Once the drug is given, it cannot be taken back. So we have to give the blockers there. But here we can use, strategies like emesis or binding to the activated charcoal. IV injection may also induce hemolysis. So it can produce hemolysis and cause other adverse reactions by the too rapid delivery of the high concentration of the drug to the plasma and tissue, also vital organs like heart, brain, etc. So it will be the brisk response. Once you give the drug, that's why some drugs ought to be given very, very slowly IV. You cannot give the push like the phenytoin case or the diazepam. We can, because there is a high potential. So that you have to take care of. And thrombophlebitis of veins and necrosis of the adjoining tissue if extravasation occurs. So in the case of this is very important in the chemotherapy, this last part. And now intramuscular route. Large skeletal muscles, we have deltoid, we have triceps and gluteus maximus and rectus femoris. These are the areas where we can anatomically we can give these drugs. And you have to make on the practical notebook skeletal muscle, deltoid muscle. You have to show it on the practical notebook. So what are the advantages? Absorption reasonably uniform, a rapid onset of action is there. Mild irritation can be given. First pass avoided. Although it is intramuscular, but first pass is not there. Gastric factors can be avoided. But there are disadvantages like only up to 10 ml of drug, not 10 ml, it is 5 ml. But now if we have a 20 ml of drug, we have to give the intramuscular. We can have identify 4 sites, 2 arms and 2 legs. So it is 10 ml is not, it is only 5 ml. But maximally it is 10 ml once there is an emergency. Local pain and abscess is there. Expensive because of the expert person should inject. Infection is there and nerve damage is there. Local hematoma can occur in anticoagulant treated patients. So these are the things which you have to enumerate. And then subcutaneous drug is deposited in loose subcutaneous tissue. That is rich nerve supply. Irritant drugs cannot be injected. Less vascular, slow absorption than IM route. So this you have to see subcutaneous. I told you the insulin is the example. Avoid in shock patients vasoconstriction. We should not give in the shock patients because there is vasoconstriction. Only small volume can be injected. It is not big volume. It is 0.2 ml. Subcutaneous injection minimizes the risks associated with the intravascular because we have subcutaneous injection minimizes it. Suppose if we give the insulin IV, there will be hypoglycemia brisk and the person can die. So that's why subcutaneous is released slowly and it maintains the response for a longer time. So depot preparation can be injected like dermojet, pellet implantation, cellulosic and biodegradable implants. So it can be slowly released there. So this is very important. You have intradermal route. Injection into skin raising bleb. The BCG vaccine is there, sensitivity test is there, like we do in the tuberculosis, and that sensitivity test, or sensitivity test in the antibiotics we give. So BCG vaccine we give intradermal route. Then we have intrathecal and intraventricular. You have to see it is, advantages. What is that? Just volume. What is how you do it? That you have the technique you have to develop, and that you have to do practically, and you just find out the literature and write. Intrathecal and intraventricular, it is sometimes necessary to introduce drugs directly into the cerebrospinal fluid. So, for example, amphotericin B is used to treat cryptococcal meningitis. So, it is the antifungal we give amphotericin B, or you can give anti-cancer drugs intrathecally, intraventricular that we call. Now here is a transdermal, is the big, discovery of the pharmaceutical agents, that the route of the administration achieves systemic effects. So once we get the transdermal, although it is local, but locally given, but its effect is ensured in the centrally effect by the application of the drug to the skin, and usually via a transdermal medicated adhesive patch. We can easily, it does not need expertise. The rate of absorption can vary markedly depending on the physical characteristics of the drug, lipid soluble and skin the entire application. So how it is? Slow effect is there, prolonged drug action. Suppose you have to go to the America, you can have the transdermal part of the scopolamine, or you can put it until you reach one day or 2 days. It can be sustained, and the route is most often used for the sustained delivery of the drugs, such as the anti-anginal drug nitroglycerin and antiemetic scopolamine. These are the two examples, main examples. There are so many drugs, but these are the two main examples which you can remember. The nicotine patch also for the this withdrawal syndrome, you can give the nicotine patch. Site is the upper arm, chest, where there is a large area, and the mastoid region. First pass effect is avoided. Absorption increases by oily base because of the lipid solubility. Occlusive dressing is needed. Rubbing preparation. So at that time, what are the advantages and disadvantages that you have to enumerate? Now the transdermal therapeutic system. Transdermal, it is drugs in solution are bound to a polymer, is held in a reservoir between occlusive backing film and rate controlling micropore membrane, under surface of which is smeared with an adhesive impregnated with priming dose of a drug. Adhesive layer protected with film which is peeled off just before application. So this is a transdermal therapeutic system. It is transdermal, it is another route, and to provide smooth plasma concentration without the fluctuation. There is no fluctuation. So more convenient, patient compliance is better. So we cannot forget it. So this is the transdermal therapeutic system. That's called the TDS. Then we have the topical application. So produce local effect, skin, percutaneous, that is allergy testing. Topical local anesthesia we can give, mucous membrane, respiratory tract, inhalation, that is asthma, eye drops, that is conjunctivitis, ear drops, we can give the otitis externa, and intranasal, that is decongestant nasal spray. These are the topical local. Now we have the inhalation, advantage, disadvantage. This is a large area, the lungs, mucous membrane of the respiratory system, and rapid absorption is there, large surface area is there, provided local action, minor systemic effect is there, low bioavailability although it is there, less side effects are there, no first pass effect is there, dosage form is aerosol or nebulizer. Only few drugs can be used, like in asthma, COPD is the disease, and you should enumerate the examples. Now this is the nebulizer, you see in children and in the asthmatic cases. These are the examples. Now inhalation. Inhalation provides a rapid delivery of a drug across the large surface area of the mucous membrane of the respiratory tract and pulmonary epithelium, producing an effect almost as rapidly as with IV injection. So inhalation, it depends upon the inhalation. So it goes the oxygenated blood and it will spread like anything. It is just like IV. The route of administration is used for drugs that are gaseous. For example, some anesthetics as those that can be dispersed in aerosol. This route is particularly effective and convenient for patients with respiratory complaints such as the asthma and chronic obstructive pulmonary disease, that's called COPD, because of the drug is delivered directly to the site of the action and systemic side effect is minimized. So effector site is lungs in the COPD or in the asthma case. Example of drug administered via the route include albuterol and corticosteroids such as flutocasone. So these steroids are given. Now intranasal, there's a discovery that in the 2000 or 2000 something, some drugs have come for the diabetes. they were, I would say, insulin preparation, intranasal, that has failed. The route involves administration of the drug directly in the nose. Agents include nasal decongestants such as anti-inflammatory corticosteroids. Desmopressin is administered intranasally in the treatment of the diabetes insipidus. Salmon calcitonin, these are the different preparations. A peptide hormone used in the treatment of the osteoporosis is also available as a nasal spray. So these are the examples which you have to enumerate. The abuser drug cocaine, the abuser drug, they are in different forms. They are in the gaseous form, they can be inhaled, there is a pain in the addiction, and cocaine is generally taken by intranasal sniffing. So these addictive drugs, they have got this, I would say, structural activity or the chemical activities relationship. Now, second topical, dermal, oil or ointment for local action, antiseptic, cream and lotion, sunscreen lotion and powders can be given through topical. So, no single method of drug administration is ideal for all drugs in all circumstances. Why? Because depending upon the, I would say, property of the drug, depending upon the, I would say, solubility of the drug, depending upon the volume of the drug, depending upon the cooperation of the patient, depending upon the unconscious state, depending upon the, I would say, vomiting center. So all these things you have to remember and make a good, I would say, note on the practical notebook so that it can be viewed, and we'll see how, those students who have nicely projected on the notebook and how it can be claimed, then how many marks can be obtained, and there will be a, I would say, Viva Voce session for this administration of drugs. Thank you very much. Have a nice day and good luck.